Hello, everyone. I'm Patricia Tinio, and I will discuss phototherapy and the role it plays in psoriasis treatment. I have no conflicts to disclose. This lecture will review what we already know about phototherapy and reinforce this knowledge while at the same time give updates. Here is the outline. To start, let's have a bit of history. Treatment with sunlight or heliotherapy has been around for many centuries, and more than 3,000 years ago, Egyptian and Indian healers used plant extracts and seeds with sunlight to treat leukoderma. Specifically for psoriasis, Dr. Alderson reported the use of heliotherapy in 1923, followed by Dr. Deckerman, who added coal tar to broadband UVB. Then in 1974, PUVA was introduced. In the 1980s, narrowband was discovered, and in 1997, targeted therapy was also started. Some definitions. Phototherapy denotes the use of ultraviolet radiation to treat skin disease, and photochemotherapy is ultraviolet light therapy combined with photosensitizing drugs such as your PUVA. This is a diagrammatic representation of the electromagnetic spectrum with numerous clinical applications in medicine and for both diagnostic and therapeutic purposes, from gamma rays to radio waves. The UV spectrum in particular is from 320 to 400 nanometers. UVR and visible light take up the 200 to 760 nanometer wavelengths, where UVC is at 200 to 290, UVB 290 to 320, narrowband is particularly at 308 to 311, and UVA from 320 to 400. Phototherapy works through a dual action mechanism which includes apoptosis and immune suppression. And although phototherapy is recognized as an effective treatment option, the exact mechanisms have not been fully elucidated yet. Studies suggest that a combination of pathways lead to the treatment benefits that we see by counteracting the immune overactivation underlying psoriasis. Before therapy, there is an imbalance in the T regulatory and Th17 cell levels, but this is restored and normalized after phototherapy. This table clearly illustrates the target cells and intracellular effects of UV therapy. Based on method of delivery, we can divide the modalities into full body or targeted therapy. The ones highlighted in yellow are the ones that we use for psoriasis. Focusing on the first and second line therapies, inside the red box, we have narrowband UVB, the excimer laser lamp for first line, bath or cream PUVA, and oral PUVA for second line. In 2019, a psoriasis clinical pathway was developed at our center. And this diagram, which is part of it, shows that we start phototherapy in patients who are evaluated and diagnosed with moderate to severe psoriasis, or in patients with mild disease but have a DLQI score of equal or greater than 10. For patients with guttate or plaque psoriasis unresponsive to topical therapy, narrowband UVB is considered, and for palmoplantar pustulosis, soak PUVA is a good option. We move on to the treatment protocols, and these are the references that I used for the succeeding slides. We need to keep in mind that there's no perfect protocol. They're guidelines for us. We should exercise flexibility with regards to interpretation, and that each patient has a unique reaction to UVL. The treatment basis is the prescribed protocol, the time elapsed, and the patient's response to the previous treatment, and any medication changes. After we determine that the patient is a good candidate for phototherapy, we decide on a starting dose. This is individualized and based on either the skin phototype or the MED or MPD, and subsequent doses are based on the response to previous treatment. This is a table showing the different skin phototypes. And the treatment phases include the starting, clearing, and maintenance phases. The clearing phase is where we want to control the activity of the condition. So PUVA is at 2 to 3 times a week, UVB 3 to 5 times. And the maintenance phase is for prolonging remission and avoiding the rebound effect with PUVA at once a month and UVB once a week. This is an example of a narrowband UVB treatment protocol based on the skin type of our patient. And if MED testing is done, then this is an example of the protocol that we can follow. And note that the initial dose is not the MED, but usually just a percentage of it. It can be 50% of the MED. For missed treatments, or if there's interval between sessions are increased, this may be followed. And this is a regular protocol for PUVA therapy. And this is for missed PUVA treatments. For oral PUVA, this is the guide for the Sorrelin dosage. To optimize treatment outcomes, we may combine phototherapy with other treatment options. UVB and PUVA may be safely given with various topical medications, methotrexate, and retinoids. Combination with cyclosporine is not commonly done, and we need to exercise caution due to the possibility of increased side effects. Many reports of UVB combined with biologics are available, while oral PUVA and biologics together also have the potential for increased adverse effects, and caution should be used for these. We usually start phototherapy on patients with a minimum of 10% body surface area involvement and guttate psoriasis. For those with severe focal psoriasis, which are resistant to topical therapy, targeted therapy is effective. So it's safe for use in pregnant and breastfeeding women, patients with renal and hepatic failure who are HIV positive, and in children who are able to follow instructions. In evaluating the role of phototherapy in the treatment of psoriasis, one key question includes how it compares to biologics. As seen in this table, we can say that narrowband is still a good choice in terms of efficacy with comparable PASI 75 and 90 scores to these biologics. In fact, this randomized study showed that patients on phototherapy had better scores than those on adalimumab, with more improvement in the health-related quality of life scores in the phototherapy group, emphasizing the non-inferiority of this treatment in comparison to a biologic. Factors related to improved PASI 90 outcomes include patients with guttate psoriasis, a decreased BMI, higher baseline PASI, non-smoking status, and a faster treatment trajectory over the initial 2 to 3 weeks can predict psoriasis clearance. Another key question involves the benefit that phototherapy gives to address the systemic inflammation in psoriasis. Here are some studies on this, and so far, the conclusion is that more data is needed before definitive statements can be made. In terms of safety, possible short-term side effects are the following. And for long-term side effects, we have photoaging, carcinogenesis, and photodermatosis. Contraindications are lupus erythematosus, XP, photodermatosis in the UVB spectrum, and we should use phototherapy with caution in patients with a history of melanoma, dysplastic nevi, multiple non-melanoma skin cancers, history of arsenic intake, exposure to ionizing radiation or PUVA, and transplant patients taking immunosuppressives. Narrowband UVB is overall safe and well tolerated, as long as we also have safeguards that are implemented, such as genital and eye shielding during sessions. For photocarcinogenesis, multiple studies specifically assessing this did not find an increased risk of skin cancer, although the theoretical possibility is there. So we just need to exercise caution for a certain subset of patients that we mentioned earlier. Broadband risks are similar to narrowband. There have been no long-term studies reporting photocarcinogenesis with bath PUVA, but phototoxicity may occur. Adverse effects of oral PUVA include the following: which you see here, has squamous cell carcinoma, although the risk of BCC is not greatly increased even with high doses. The factors increasing the risk of SCC include low skin types, high-dose PUVA, a history of skin cancer, the presence of actinic keratosis, and treatment with cyclosporin. So for some practical considerations, we know that office-based phototherapy is safe and effective, but this may be time-consuming and inconvenient. So home phototherapeutic approaches are a good alternative. But we just need to make sure that we guide and educate our patients before starting the treatment and during the treatment. Now, one study that developed an innovation in home phototherapy systems with a smartphone and a server and a physician web-based portal helped improve patient adherence and satisfaction. For future directions, there are new designs of phototherapy devices and tailored treatment protocols being done, identifying biomarkers which may predict response to therapy and help in patient selection. Studies to improve efficacy and safety of light therapies are ongoing, and studies to clarify which modes of action play a larger role in the treatment of psoriasis and how these mechanisms are related, and more studies to determine if phototherapy has a beneficial effect on the systemic inflammation in psoriasis. Summarizing the important points we've discussed, there have been numerous clinical studies that demonstrated the safety and efficacy of phototherapy for psoriasis. Narrowband and PUVA are the most widely used applications. Broadband and narrowband UVB have not been linked to cutaneous carcinogenesis when treating psoriasis, although oral PUVA increases the risk of squamous cell carcinoma. Targeted phototherapy is very good for localized lesions, less than 10% body surface area involvement, or for scalp and acral areas. And lastly, even in the era of the highly effective biologics, UV phototherapy still represents an important and indispensable therapeutic tool in the treatment of psoriasis and in dermatology. Thank you very much.